Hi everybody, my name is Dr. Cole Zanetti. I'm a combined family medicine and leadership preventive medicine resident at Dartmouth, and I'm going to be talking to you a little bit about public health informatics and my particular experience with it. I'm going to tell you a little bit about my journey when I helped the state of New Hampshire transition their Syndromic surveillance system into an emergency room hotspotters map for the entire state. I'm going to walk you through my experience and basically talk about some of the obstacles that we encountered, some of the ones that we're currently dealing with, and what our next steps are related to this innovative model. We're essentially trying to use data to be more strategic about healthcare delivery. There is a lot going on right now to capitalize on big data. Both in the public health sector and in the clinical patient encounter. And what my job is as a family medicine and preventive medicine resident is trying to fuse both the public health data with clinical data, or at least allow them to work more fluidly together in order to change how we care for patients both as individuals and as community members. So when I first walked into the Department of Public Health, I was actually on a rotation there. And I was being toured around, and I was first exposed to a syndromic surveillance system. I've never heard of it before, and I was completely blown away about its capacity to make change in our current healthcare system. But what it's currently being used for is not necessarily what it could be used for to maximize its full potential impact in patient care and healthcare delivery change. Before I had that experience, I was exposed to Dr. Atul Gawande's article about hotspotters. The one where he spoke about Dr. Jeffrey Brenner's attempts in Camden, New Jersey to identify high utilizers of the emergency room system in Camden. Through that process, they collaborated with a number of local hospitals in Camden, New Jersey, was able to analyze the emergency room data and identify who those high utilizers were, and end up realizing that 1% of the 100,000 people who made use of Camden's medical facilities accounted for 30% of its costs. Now that was startling to me, but what was even more fascinating is that he was able to identify that 900 people of those overutilizers lived in 2 buildings, and that accounted for more than 4,000 hospital visits and $200 million in healthcare bills. So this concept of identifying where these high utilizers are actually located and trying to strategize how to allocate resources to these concentrated locations of overutilizers may have a chance of impacting and improving care. So Dr. Brenner essentially took that concept and created care teams in these 2 buildings that housed 900 of these patients, and measured the long-term impact of these care teams localized in these areas. The long-term effect on the first 36 superutilizers who averaged 62 hospital and ER visits per month before joining the program ended up only using the ER 37 times after that intervention. That's a 40% reduction in ER utilization by acknowledging and realizing where these high utilizers are located. The hospital bills of these particular patients averaged $1.2 million per month before, and just over $500,000 after, a 56% reduction. So my exposure to this article before I walked into the doors of the Department of Public Health was very influential. It made me realize that we have information out there currently that if we capitalize on its potential for changing our delivery and strategic approach to delivery of care, we can have a huge impact. And Dr. Brenner's Camden Coalition showed that. So when I walked into the doors of the New Hampshire Department of Public Health and they first exposed me to the syndromic surveillance system in the state, immediately I made the connection of, well, are you using this for emergency room overutilization, identifying measures? And what they described to me was essentially what the system was initially built for. So the syndromic surveillance system was initially set up in 2001, and states all over the country who began setting up this system implemented it or started to create it for early event detection of emergency preparedness, communicable disease, and other public health threats. They collect emergency room data in real time in order to do this. And now that's a key difference. A lot of public health data is kind of retrospective. It's after a few years. This is the first system that I was exposed to in the public health realm where it was actually real time. We would obtain this information within 24 to 72 hours, which is incredible when you look at it from the public health timeline. Specifically in New Hampshire, the Division of Public Health began their syndromic surveillance system in 2005, and up to this date has included all 26 New Hampshire hospital emergency departments. So essentially we have data coming in from almost every single emergency department in the state, and it's live, it's real time. And they've had this information since 2005. Not every hospital was involved initially, but they've increased relatively rapidly to have access to almost every hospital in the state of New Hampshire. So we have years of data related to this. So the next question is, how is it currently being used? Specifically in the state of New Hampshire, it's used for disaster preparedness and outbreak identification. So those two things were the only things it was being used for when I first interacted with this in 2011. The data obtained from this system included the patient's medical record number, the patient's date of birth, the town of residence that the patient is from, chief complaint with associated diagnosis codes for why the patient is coming into the emergency room, date and time of visit. All of these things would shoot right over to the Department of Public Health immediately following the patient encounter. Now, the other element that I need to touch on related to syndromic surveillance is this big push by the CDC to create Biosense 2.0 system. A Biosense 2.0 platform is essentially a way for all of the syndromic surveillance systems to be able to share their data. And it allows for ED syndromic surveillance oversight through the CDC and other states to be able to identify different things that are going on. Now, the idea of this project was if we're able to convert our syndromic surveillance system, which was just being used for those two previous things, to an emergency department overutilizer hotspot system or hotspot map, and we develop it in a way that's manageable and is streamlined, then this mechanism could be rolled out to participating jurisdictions. National detection of overutilizers could be possible across the entire country through Biosense 2.0. So we wanted to be able to share this, essentially create a streamlined path of transition and share it with all those that have syndromic surveillance, allow that to be uploaded or streamlined through Biosense 2.0 so that we have that data available across the entire country, which would be incredibly unique. And the goal of this is through this shared information, we have a potential chance of collaborating across hospital systems, across network lines, collaborating with departments of public health to target particular towns or areas within each state that is in high need for strategic intervention. And that was the initial idea. So then we had to work through, is this possible? Now, the first thing that we encountered were the major obstacles to this project, and that dealt with data cleansing. This project was essentially, or the surveillance system was just built for early event detection. It wasn't necessarily built to have a very clean data set. So there was a lot of work, and we're still currently doing this actually, of data cleansing in a way that we're able to take out all the duplicates in the system, which there were a lot of, where hospital institutions were actually putting the information of the same patient in more than once because they didn't realize it went through, to capturing data from urgent care centers that were wrapped in as part of the emergency department instead of a separate entity. Now, we realize that each of those departments and urgent care centers now have a different code that they send, but our system was basically wrapping everything together. So there were a lot of data cleansing needs to address, of which we have worked with an outside consultant to address this, and within the next month or two in the state of New Hampshire, those duplicates and the data cleansing filter will be in place so that when live data is sent to us, it goes through this filter and we have accurate data. And we're able to test this by essentially applying those filters and assessing its accuracy from historical data. The other obstacle that we encounter is that the data doesn't typically have the patient's insurance and cost information, which would provide some greater insight into the patient and how they impact medical care. Another feature that I would consider as an obstacle is that we don't have the specific patient's address. We only have down to the town level. We have a lot of public health data otherwise down to census tract level, which is smaller than the town for most instances. Census tract is actually more related to the population size. So there are some towns that have smaller populations. So census tract might actually include a number of towns if the population is small enough. But being able to delineate whether a town is smaller or census tract is smaller and more granular for public health data is achievable. But through this system, we only have town data. So that is an obstacle limitation when we want to try to get down to the most specific location area. So those are some features of limitation. Other features of limitation that I think were identified is that some hospitals didn't share medical record numbers. So most of them did, but only I think one didn't share a medical record number, but they did share all other information. So those were some hindrances that we had to try to deal with through this project's development. So the idea and the goal of this project was to create a GIS map of events with layered data. So we would be able to create a live feed to an API, which would be secure and only accessible by hospital systems, analytics departments after they went through appropriate security assessments and signed a contract. All of this stuff is still in development. Our goal is to create this API GIS map a GIS map located on an API for hospital system analytics teams. But essentially creating that map that is real time that shows the overutilizers and where they're located by town. We also wanted to layer this map with other data that may be relevant, and I think all data in the public health sector is potentially very useful for point of care decision making, and at the very least for predictive analytic risk score development. What we're currently trying to work on is taking more customized public health data to the most granular level and most up to date. And providing that for healthcare networks in a customized way that only provides data to their particular for their particular town network coverage, so that they can apply it to their analytics when they're doing population health risk assessment. So we wanted to be able to layer all this data on top of the ED overutilization map. And we decided to use the social vulnerability index as our first data layer to trial with. And the social vulnerability index is basically the potential for loss of life or property due to hazards. It represents social, economic, demographic, housing characteristics that influence communities' ability to respond, cope, or recover and adapt to environmental hazards. So to me, this was fairly representative of the social determinants of health based on the data that we collect that we could assign to particular towns and populations. So what we did was create a map of New Hampshire showing the super utilizers, and that's in white to the color brown from lowest to highest, showing areas where the highest number of high utilizers were located in the state. And then if you look at the small dot to the larger dot, that shows the higher level of social vulnerability index in those locations as well. So we can actually see if there is a correlation between the number of super utilizers and the number of and social vulnerability index. Now let me define what a super utilizer is. An overutilizer is essentially defined based on research of people going to the emergency room 4 times or more within a year. Our determination of a super utilizer was someone that went to the emergency room 7 times or more during the year. So then we wanted to look for a particular correlation between the two, and we were able to find that there was a 15% correlation when ruling out for other factors between the higher number of super utilizers and the higher rate of social vulnerability index. And this is just to give you a picture of what is possible once this system is created. You could find these features and layer them on top of each other to help better draw a picture of what might be going on in the community of those that are most vulnerable and overutilizing the emergency room systems. Now, this isn't by any means saying that this is the cause of why people are going to the emergency room, but it gives us a better picture of what might be going on. So this is the next step section. Our goal at this point is to streamline the process that we created through R to create a live feed on a secure API for all hospital systems in New Hampshire. When we originally did this, we actually did it through Excel, which is a very limiting system because we were working with a lot of data. So it took a lot of time to work through the development of different algorithms to create this. So we're actually working with a team that are experts in R to streamline this process and apply the algorithms so that once data comes in, it's filtered, it goes through the deduplication process, it goes through R to plotted out on a GIS mapping system and creates a live feed. We also are trying to layer all public health data that is the most up-to-date down to the census tract or town level, depending on what's more granular, on this map. So it would be interactive, and hospital networks would be able to select the towns that are within their catchment area or their network, and extract all the data concentrated within that area and apply it to their analytics system. We also want to link each data point, so let's say unemployment rate as an example, to a local resource that is available for intervention. So public health resources, business resources that are locally accessible to help intervene for that particular problem in that particular area. I also am working on developing further linkage to grant opportunities to fund initial interventions related to, let's say, unemployment, if that's the indice that we're looking at. But it could be any indice for that matter. But the point of this development was that we don't want to just point out that there is a problem. We want to create evidence-based opportunities for intervention and funding opportunities to help further develop a timely action-based motif when we present this data. I need to know what local resources are available for intervention and what grant funding opportunities could I tap to collaborate with local organizations to intervene to best help and improve the health of my patient panel and my community. All of these things need to be in the back of your mind every time you approach a public health informatics project. You want to be able to make this actionable, and you want to be able to best collaborate with clinicians and care teams that are on the ground so that everybody can work in unison. So the final step, which all of these steps are actually being done in tandem, not one and then the next and then the next. We're actually trying to create an easy way for data access so that health systems can capitalize on this data for real-time analytics for better population health management. There is a lot of security issues. There's a lot of HIPAA issues that we have to work through, and we're working on developing streamlined policies in our state so that people have access to this data in a real-time manner. And the hope for all this is so that we can create this opportunity across all states, because I truly feel that this is a first step of many steps to come to improve the health of our nation. So that was my project experience. I'm still working on it, and if you have any questions at all, please email me. My email is colezanetti@gmail.com, and you could email your professor if you need to get that again. But it was a pleasure speaking with you today, and I look forward to hearing about the amazing things that you guys will be doing in the future. Thank you very much.